Welcome, and thank you for joining Speak Up for SaferCare. Speak Up for SaferCare is a product of SaferCare Texas, the patient safety division at the University of North Texas Health Science Center in Fort Worth, Texas, where it is our mission to challenge traditional thinking to eliminate preventable harm. Speak Up for SaferCare illuminates gaps in care, process, or design that lead to preventable harm in all healthcare settings. I'm your host, John Sims, Director of SaferCare Texas, and joining me today is a special guest, Dr. Teresa Wagner.
Hey, John.
And our guest is Katie Grennan. Katie Grennan first started working in birth in 2010 as a doula, and a doula is a childbirth coach. Then she became a certified professional midwife and licensed Texas midwife in 2014. After 6 years of delivering babies at home and birth centers in the DFW area, she got her RN and BSN from the University of Texas at Arlington. She is now in her second semester studying nurse midwifery at Texas Tech in Lubbock, anticipating the completion of her MSN in the summer of 2023. Katie loves working with women and families and providing evidence-based care that is safe, comprehensive, and woman-centered. On completion of her master's degree, she hopes to practice in an area hospital as a certified nurse midwife and advanced practice nurse. Wow, impressive background, and I love your passion. Explain what led you to midwifery.
Well, when I was pregnant with my fourth child, I decided I wanted to do the whole all-natural route, and so I, took a Bradley childbirth class. I hired a doula for myself, and I learned so much in that process. I used an OB in the Denton area. I had a phenomenal experience. And through the whole process, it just really kind of lit a fire in me for evidence-based care. And I really wanted to help other women do the same thing. So I became a doula first to kind of see if my family could survive the on-call lifestyle, and then really wanted to pursue midwifery to be able to provide care to women and families and birthing people in our area. I love evidence-based care. I think it's so important to use the science that we have to give women greater quality of care. And so that kind of led me to start that path. And then, it's been a process. So as I delivered babies at home and at birth centers for years, and I loved it. I loved what I do, but really wanted to be able to serve a bigger population of women. So decided to go back and get a nursing degree, and then become a nurse midwife so that I could work both in hospital and out of hospital and meet the needs of more families.
Well, thank you for joining this journey, and I love your passion. It's very needed, right? Our session today, this is our 9th episode, and it's entitled Maternal Challenges from a Certified Midwife's Perspective. And so my next question is, maternal mortality, is it a nationwide problem? And where does Texas rank?
Okay, yes, it's definitely a nationwide problem. The CDC says about 700 women die each year from pregnancy-related causes.
Wow.
And about 2/3 of those are preventable. So in 2022, we need to do better than this. The U.S. is, arguably one of the wealthiest countries in the world. We have all this advanced technology at our disposal. So what is going on here? Why is this happening? According to the World Health Organization, the U.S. ranks about number 57 in maternal mortality rates. And there's countries like Iran, Russia, Albania, and Taiwan that have better maternal mortality rates than we do.
Wow.
So it's kind of shocking. Within the U.S., the 10 states with the worst outcomes for mothers, Texas is number 8. So we've got a big problem here. In Texas, we're losing 34.5 moms per 100,000. So that's a lot.
Yeah, this is a big state. That is a lot.
Yes. Yes. So we've got some work to do.
Well, when I first started hearing about the statistics around maternal mortality when I was writing my very first grant, I started thinking to myself, because I'm a health literacy expert, and I thought to myself, well, why are these women dying? Do they even understand that they're at risk? So what I want to ask you is, what part do you think health literacy plays in maternal health, morbidity, and mortality?
I think it plays a big part. I think, when I look at my role as a provider to women, I see education as a huge component in that. I really need to educate my patients on what's normal so that they can also identify what's not normal. And then continue to a big part of our appointments is dialogue about what to expect, red flags, warning signs, these kinds of things that can help women identify, when they need to reach out, and then making sure they know that they can reach out. They can reach out. They can call their provider after hours if they need something. They can go to the emergency room if something is wrong, making sure that they know that we're accessible to them to meet their needs.
Yeah, and they need to be sure that they tell us that they recently had given birth, because many times women show up at the emergency department and don't say that, very important piece to their care, and then they don't get the treatment that they need, and it ends up catastrophically.
Right.
So as a part of my research on health literacy and new moms, I developed an app called What About Mom? Have you seen that?
I have seen it. I've looked over it. Yes, I think it's a great resource. I think, I loved especially the piece on postpartum hemorrhage, having there's pictures in that app which show you what is a normal amount of bleeding. This is so important. Hemorrhage is, according to the statistics that I've read, the number one killer of women postpartum. So it's a huge problem. So knowing what to expect, what is normal, what is not normal, when to seek care is a huge component to that.
Yeah. So do you think moms often overlook or providers underplay postpartum symptoms that might be detrimental to their health?
Yes. I think sometimes, yes, both. I think, I think that a lot of times, especially when you're in a big practice with a lot of doctors, and it feels kind of distant. You feel kind of distant from your provider. Sometimes you see different providers at different visits, or your main doctor may not be the doctor that delivers your baby, or you call the after hours line and you don't get the person who has been seeing you for your prenatal care or postpartum care. So I think sometimes it's hard to, as a mom, to communicate and make yourself heard. And I also think sometimes as a provider, it's hard to understand, what exactly is going on when somebody comes with a complaint.
And I think that's probably even more true for like teen moms or women from marginalized backgrounds who aren't taken seriously because of implicit bias.
Definitely. Yes, I agree.
Sure. So going back to the What About Mom app, very, very simplistic, and the pictures are wonderful because it shows you a picture. It's not just a bunch of words, right, that says if you got this much blood on the pad, then do this. There's an actual picture, right? And I think that's very important. And I think not just with maternal mortality, but with a lot of healthcare information needs to be done in that format, in my humble opinion. So we've talked about some contributing factors to poor maternal mortality in Texas, which, as you noted, is number 8th in the nation, and we're number 57th in the world.
Yes.
So we've got some work to do. In patient safety, sometimes we get bogged down with, I hate this verbiage, but it's used a lot. Well, that's the way we've always done it, right? So what are some things maybe that you've seen that this is the way we've always done it, that perhaps we need to change to have better outcomes?
Oh, man. Let's see. Well, for starters, I think we need to really challenge our practices when they don't line up with, what ACOG says and what our guidelines say.
So for our listeners, what does ACOG stand for?
So ACOG is the American College of Obstetricians and Gynecologists, and they put out a bunch of protocols. They take the evidence and they give us some standards that we can follow. And there's a lot of times that providers can choose to deviate from those standards, and we do want our care individualized, which is massively important. But sometimes we kind of play on the lines of overly safe in one area, but it ends up leading to more risks in another. So like an example of that is induction. If we arbitrarily induce every woman at 39 weeks because we're afraid of fetal demise, past 40 weeks, we run into some other problems that lead to problems down the line. So there's a huge correlation between induction and cesarean rates. So especially in our first-time moms, and our moms that have never had a baby before, we induce them at 39 weeks. They're significantly more likely to have a cesarean. Cesarean is major abdominal surgery. You're going to bleed twice as much. You're going to have the potential for higher risk of infection. All these things that lead to increased risk. So, and then down the line, she's at risk for uterine rupture in her next pregnancy, which is something that, we need to consider and take seriously, and that will affect her care in her next pregnancies. So if we re-examine what we're doing with that 39-week induction and not do that arbitrarily for every person just because, then we can maybe mitigate some of those risks down the line. Does that make sense?
Sure. Listening to you talk, it's a long-term complication, but I know with any major abdominal surgery, you're at risk for adhesions, and so bowel obstructions adhesions that require sometimes another surgery, right?
Yes, and that's a lifelong complication. That can happen in that woman's life, as long as she's alive. That is a complication from that, any abdominal surgery, but
Sure.
Yes.
So follow up to that question, why do you think obstetricians are opting to, when they induce, that we're having more cesareans? Why do you think that is?
It's complicated. It's hard. It's multifaceted. I think a lot of times we get focused on this pregnancy without looking at the big picture. Well, this mom might want to have 5 kids, or maybe this mom will only have 2 kids. But a lot of pregnancies are unplanned. So even if she's only planning to have 2 kids, she might end up with a couple more. But I think it's really easy to get focused on this pregnancy and this baby, which we want to have a good outcome with. And so looking at the big picture of this woman's family planning and life is a little bit more remote. But we also have risk factors affecting this pregnancy. And we need to address those too. I mean, if there's a good indication for an induction at 39 weeks, then that's what we have to do for sure. But if there's not, and we're just doing it because it's arbitrary, then that's what I'm saying we really need to rethink.
Do you think that the low access to care, especially in rural or remote areas, plays a role in maternal mortality in our state? Especially, when we talk about best practices, many of those, if they even have healthcare services, are small and have limited resources. So they may not have extra blood on hand or, some of the things that are necessary to save a mom that gets into trouble.
Sure. And I think, when we think we can control when and how birth takes place, which is a lot of our planned inductions and scheduled cesareans and stuff like that, we feel like we can be a little bit more prepared for those unknowns. So that's a factor to also consider. But yes, there's a lot of rural communities that have very limited access to good pregnancy care. And I think that's something that in the state, nurse midwives can really step into that and help fill that gap a bit.
Yeah, I think that's great. I really do. The other thing that I'm thinking about is with the pandemic, we've got healthcare worker shortages, providers, nurses, everybody, right?
Yes.
And so I have to wonder if in the past or even in our future, could induction leading to cesarean births, could that be kind of an answer to a scheduling problem for the provider? The provider is available during this time. If we can do it in a, quote, controlled setting, then we can, you know what I mean? Do you follow what I'm saying?
Yes, I do. And I think that that's a big part into why we're doing some of these things.
So suppose that there's moms listening to this right now. What advice would you give them to empower them to prevent a poor outcome in their childbirth?
What I tell my moms is that I want you to take ownership of your care. Your pregnancy, this is your pregnancy. This is your body. This is your baby. I want my patients to play an active role in their own care. And I think that that's so important. If you don't understand something your doctor or midwife is telling you, then ask for an explanation. Be involved. Make sure that what they're recommending to you is something that you feel like you can really do. Your choice in provider matters. You really want to find somebody that you can trust, who listens to your concerns, who treats you like an individual. I think preconception counseling is really important, especially if you're going into pregnancy with known risk factors. Anything you can do to mitigate any of your risk factors is massive at setting yourself up to have a low-risk pregnancy or as low risk as possible.
It's definitely a whole health model of maternal care, which is great because that's what we want, is for people to be engaged. And after birth, that's why we created the What About Mom app, is so moms everywhere, including rural areas and with low health literacy, would be able to potentially save their own lives.
Yes,
Certainly.
Definitely.
And to follow up on that, in our episode 5 and 6, we had Ray Gonzalez on, and he's a nuclear power expert. And
Wow.
I'm a huge advocate for patients not being called patients or clients or customers, but partners in their own care, right? What he did before any of his family members have surgery is he calls a huddle with the whole team there. And one of the questions he asks is, if there is something unusual or uncertain, can I trust that you're going to stop the line and figure it out before you proceed on? And in the example that he shared, his medical team was all about that, right? Because they had gone through that training on human performance, and so they knew exactly what to do. But I just question: our partners in care, do they have that? Do they feel empowered to do that? Do they feel empowered to say, "Hey, we're all in this together. We're on the same team. I'm getting ready to be put asleep. I just want to make sure that you're going to stop the line if something goes wrong."
Definitely. Yeah. And I think also, like, there's you can't underplay the role of just lifestyle modifications. Quit smoking if you're a smoker, or at least reduce the amount of smoking that you're doing. Exercise. You don't have to do anything complicated. Just walk 30 minutes a day. Eat a variety of foods. Eat healthy. Skip the Cokes, those kinds of things. Those little changes that we make in pregnancy really go a long way. We're growing a baby. We're also growing a placenta. We're also growing a uterus. The uterus is going to grow exponentially during pregnancy, and it's a muscle. And I tell people, just like we see these Olympians, and they eat a nutrient dense diet so that they can perform at peak level. We want our bodies to perform at peak level during pregnancy, so we have to feed it well. And it doesn't have to be complicated. It doesn't have to be expensive. Just basic, good variety. Eggs every morning. Milk, just the basics, some vegetables and whole grain, and keep it simple.
That's great. I love your analogy of the sports player, because you are. I've had 2 children. It is like running a marathon.
Yes,
definitely. And so we have to train for that.
Definitely.
But, we also have to reach out to marginalized populations that don't have access easily to nutritious foods, and
it's true.
Develop programs that can reach those people. But we know that African Americans tend to be a marginalized population that has the highest risk of maternal morbidity and mortality, or having bad outcomes from birth. So why do you think that is? Have you looked into that?
Well, I think it's complicated. I do think that a lot of this comes down to implicit bias. And I think we need to address that as healthcare providers. We need to continue to educate ourselves and identify and do the cultural competency stuff and all these things. It's important. It's saving lives. I think, Black women are dying at a rate of 3 times higher than white women in this country from pregnancy-related causes, and that's a massive and shocking statistic to me.
I agree.
We need to address this, and I think some of it is some implicit bias, but I think it's a lot. There's probably other factors as well. But what we do know is that when we adjust these studies for socioeconomic status, we know that that's not the issue. I read one statistic recently that said that Black women with a college degree still have a 60% higher risk than white and Hispanic women who haven't even graduated from high school. So that should shake us up. Yes, It should shake us up.
Yeah, so it could be related to systemic racism.
Yes.
That, with microaggressions and stress over time, along with other chronic diseases that African Americans tend to have a higher risk for as well. Because if you go into pregnancy with high blood pressure
Correct.
Or diabetes, then your outcomes are more likely to not be good.
Those are risk factors. Yes, exactly.
Yeah. And so that's, again, goes back to your mitigating the risk factors. So if you know you have those things, then try to address them headed into pregnancy with that whole health mindset.
Definitely, yes.
If you could change one thing about the perinatal process, what would it be?
Okay, one thing is hard.
There's a lot.
I have I could name a short list. I think we've got to address those routine inductions. I think that is that we really need to challenge doing that arbitrarily just because. I also think that we need to stop doing repeat cesareans on women just because they've had a previous cesarean. ACOG really wants us to be offering VBACs, which is VBAC stands for vaginal birth after cesarean. They really want us to be offering VBACs to our moms that have had 1 and sometimes 2 cesareans under the right situation and circumstances. And when we do that, I mean, a vaginal birth is just going to be less complicated than major abdominal surgery. It's going to carry less risk of hemorrhage. It's going to carry less risk to that mom long term down the line. So I think that's a big thing that we need to be advocating for. I think postpartum care needs to be more thorough. Some OBs will see their moms before discharge at the hospital and then not again until 6 weeks postpartum. So much can happen during that time. Just talking about preeclampsia, 25% of preeclampsia is going to happen in the postpartum period. How are we going to catch those moms if we're not seeing them? So we need to see moms more regularly in the postpartum period. And I think we really need to give moms individualized care. I think that that's so important. Every mom, we talk about these standards and these protocols, and they're great, but how we apply them is the art, right? So we need to look at that woman as a whole and all of her risk factors and her lifestyle and her family even to some extent, and really see what we can do to customize care for each of our patients. Does that make sense?
Yes, it makes perfect sense. In my research on health literacy, what we found was that each woman would get a different discharge instruction. And so they might cover, high blood pressure or the potential for strokes, but then they didn't cover if you have swelling in your legs, it could potentially be a blood clot. And so there were all of these risk factors or things that they should be monitoring. Again, why we developed the What About Mom app that would help them get through that 6-week period of time, hopefully identifying what's going on for themselves and seeking emergent care if needed.
Yes.
Well, thank you, Katie, for sharing your knowledge and expertise today, and thank you for listening. Speak Up for SaferCare is a product of SaferCare Texas, the patient safety division at the Health Science Center in Fort Worth, Texas. We'd like to thank our technical producer, Rob Upchurch. We are calling you to action. Speak up for SaferCare. If you are a healthcare worker, counselor, subject matter expert, former patient, or caregiver, and have a patient safety story, SaferCare Texas invites you to be our next guest. Please contact us through our website, safercaretexas.org. Also, follow us on Facebook, Twitter, Instagram, and LinkedIn at SaferCare Texas. We'll talk again next Wednesday. Thanks again for listening, and as always, speak up for safer care.